It appears we may be nearing the end of the worst of the latest COVID surge in this region. Virus levels in wastewater in and around Boston have started dropping, which some argue is an even better indicator than state testing data. But as always with this pandemic, it's not over till it's over. Experts are warning that hospitals are still going to be stretched thin for weeks to come, and that we still need to be vigilant in protecting ourselves and others from COVID spread. That's why Joe Biden announced another initiative today, part of what he's calling a whole-of-government surge response to the pandemic.
We are making high-quality masks available to the American people for free.
About time. But as with the whole testing thing, he hasn't said exactly how yet, with details to come next week. He also announced another 500 million free at-home tests are coming on top of the 500 million he already announced, with a website for all that also set to roll out next week. And rapid tests, those at-home kits you wish you had more of, are what my next guest has been trumpeting almost since the start of the pandemic, long before we even had a vaccine. Dr. Michael Mina is a former assistant professor of epidemiology at Harvard School of Public Health. He's now the chief science officer at eMed, which provides a range of at-home diagnostic testing. Doctor, it's good to see you again. Thanks for being here.
Good to be here. Thank you.
So for the terminally confused, and I am among them, the mantra that we have been spouting until recently was that antigen tests are not as reliable as PCR tests. Thus, PCR tests are the tests of choice. We are wrong. Why?
Yeah, so the PCR test is a very good test if you're a physician trying to get every shred of evidence about whether your patient is currently infected or was recently infected with a virus like coronavirus. But the vast majority of people and the vast majority of times that somebody's going to get tested, our question is not, have I been infected in the past? Our question is much more simple and straightforward. Am I infectious now? Do I need to isolate? Am I okay to come out of isolation? For that question, the antigen test is a much more reliable and accurate test to give you that information, because a PCR test can stay positive for weeks after somebody is no longer infectious. And an antigen test is very specific, meaning it will only turn positive when you are currently infectious and a potential risk to the people around you.
But when people respond to what you just said by saying something like, well, but the PCR test is more sensitive, that's why you respond by saying, I think, in fact, it's too sensitive for our everyday purposes. Am I right about that?
That's correct. It is too sensitive. I like to give an analogy of a detective versus a security guard. If they're both there to help stop crime, but a detective can go back to a crime scene weeks or months or even years sometimes, after, and pick up little shreds of DNA and use PCR to figure out who was at that crime scene. That's very different than the kind of person we need to stop the crime from happening in the process of it occurring. And that's where you really need a security guard or a security camera, which is very different than a forensics detective who might just happen to show up there at the time that the crime is happening, but more often will show up afterwards. And so the two tests are just used for very different purposes. And in the case of a rapid test, it's really about finding out, am I infectious? Do I need to isolate? And the most important thing falls right in its name. It's a rapid antigen test. It gives you results in a time frame that allows you to actually act and stop yourself from transmitting any further.
So when I first started reading your stuff a couple of weeks ago, and we had you on the radio, you convinced me, and then all of a sudden, the next day, I read a story in Stat about admittedly a small test, in which the conclusion was that rapid tests didn't detect Omicron in the first few days of infection. The point of the test being you could be transmitting and not even know you have it. Isn't that a big problem?
So it's not an issue with rapid antigen tests. And this is where there was massive confusion around that study. What the study was actually comparing was the use of saliva as a specimen versus a nasal swab. And when you use saliva, we've known actually the entire pandemic that the saliva can turn positive a day or two before the virus gets a chance to migrate up into the nose. And so it was actually kind of a disingenuous title, because it was really more about comparing the specimen type, where the collection of the specimen is coming from in the body, But what we know from both from that study and studies that have come before and after it is that the rapid antigen tests are still performing exactly as we anticipate that they will perform to detect Omicron in the same way that it was detecting Delta or any of the other variants. Now, what has changed is Omicron is obviously much more transmissible. And so there is a period of time on the ramp up when no test will find you in as positive in the nose, but you might already be spreading because the virus is kind of down in your saliva and your throat and already aerosolizing. And so that's a much more difficult problem that both the antigen test nor the PCR are able to solve unless you start collecting the specimen from further down or from the saliva.
So let me state, I guess, what is the obvious based upon your conclusions. For those who are obsessed, as we should be, about lockdowns that are killing businesses and workers, maybe not literally in some cases, but figuratively, school closings and the damage they are doing, the rapid test is the antidote for both of those problems, according to you, correct?
Yeah, and the reason is we want to stop transmission. We absolutely want to stop transmission. And so a rapid test is a very good tool to do that. As long as we're still, as a society, choosing to stop outbreaks by locking things down and keeping people at home, then what our real goal is to stop transmission. The rapid test can help identify you in a time period that is commensurate with what you're using it for, stopping you from spreading to others. But the other important piece is that removing yourself from isolation is absolutely crucial to do in a safe way. And right now, the five-day guidance, for example, from CDC, just has anyone leaving isolation at 5 days after they've been into it. But what we know is that many people are still positive and infectious, some of at their peak infectivity at 5 days at the very time they're leaving isolation.
So you think they've got to take a rapid test and have a negative, unlike what the recommendations from the CDC are, correct?
Yeah, that's exactly right. And unfortunately, the CDC kind of had its hands tied because we don't have enough tests to recommend that as a nation. But the reality is, if you can get the tests, we should really be trying to focus the small amount of tests that we do have access to these very high utility kind of efforts where I think test out of isolation is one of the best approaches and best and most effective ways to use these tests currently.
But even if we get over, well, let's talk about the embrace of late of your message. Here's Governor Baker, for example. I think it was this Tuesday, testing in front of the legislature.
I would actually argue that rapid tests are a better way of measuring when someone's over COVID than a PCR test is. We have lots of anecdotal information that employers are requiring PCR tests to go back to work. They shouldn't be. They should be requiring rapid tests.
And the president seems to be there too with this 500 million tests at some point coming, hopefully in January through a website. Another 500 million tests. After that, he announced today, far better than his original, I think, absurd plan to have people buy a test and then submit for reimbursement to their insurance company. But even this latest test, with the history of websites like Obamacare, for example, are you confident this vehicle will be adequate to distribute a billion tests to the American people? And by the way, a billion's not even enough, is it?
Yeah, well, I'm not a logistics person. So in terms of knowing exactly how much USPS can handle, how much the website can handle, what I would say is I think it's certainly effort in the right direction. And I do think that we now have new leadership around testing in the White House. Tom Inglesby is a Hopkins professor, has just done a great job throughout the pandemic. And I feel encouraged having somebody like him now taking the helm, that if it's not working out, I hope that they're going to shift and try something else that will get the tests out to people. For example, Ohio is a terrific example of a different approach where Ohio and actually the company I'm now at, eMed, partnered early on to make tests available for free to people. And people could just go into the library, pick up a test. There was no shipping to individual homes, but making it very, very accessible by putting it in a lot of different places. So there's a lot of options here.
I know history is not terribly useful. Let's just spend a minute. A couple days after you were on the radio with us, Irene Bosch was on the radio with us, for an MITer who developed a rapid test within weeks of us learning about COVID-19, was denied by the FDA approval at the same time that Europe is approving these tests in rapid fire to the point where she told us you can buy a rapid test readily available in places like Germany for 50 cents. Why were we so backwards or so slow in regulatory agencies putting a stamp of approval on these things?
Yeah, well, we have, on the one hand, our FDA has always been considered, or for a long time now, has been considered a gold standard for safety. So they're uncompromising in that regard. But on the other hand, we're not exactly the most innovative in how we think about things in this country. And for example, in the regulatory landscape, we only have a pathway that's focused on medical diagnostics for a physician to be using for their patient to be able to say something, have you been infected in the past couple weeks? And regardless of time, regardless of being a too sensitive and turning a positive when you're no longer infectious. And our regulatory landscape just doesn't have a familiarity with authorizing a test for a different type of medical or public health use. And it has bogged everything down to this day, unfortunately.
You know, this, even though I'm totally bought into what you're pitching, this rapid testing, and obviously leaders in this country finally are too, that's only one obstacle. It's not a cure-all. One, people have to figure out how to use them. And by the way, the first use, as you probably know, is not so simple with these microscopic directions. And then if they test positive, they have to figure out what the next step is. How do they get access to those hard-to-find antiviral pills? So there's a whole spectrum of things that needs to be done, not just making these available and affordable, Doctor.
Yeah, that's exactly right. And I mean, to be very honest, this is one of the major reasons that I left Harvard was to solve this problem. At eMed, this is exactly the problem that we're trying to solve, which is when somebody wants to use a test and not sure how to do it, a proctor actually pops up on their computer screen and walks them through how to do it without having to go to a site. And now we're also creating a test to treat program so that somebody can have these tests. A vulnerable person, elderly person has them in their home. At the first sign of feeling symptomatic, they can take the test, and if they're positive, they can get a treatment, ideally delivered straight to their door. So that's kind of what we're working on now. And because to your point, getting treatment, helping people to access these life-saving treatments now that they exist is a major obstacle. Doing it in a time frame that the treatment is still going to benefit them is a massive obstacle. And I'm trying to create a pathway now with eMed to solve that particular issue.
We only have a couple of seconds, and I hate to end on this kind of question, but I'm going to do it anyway. 867,000 people dead in this country. If we had had an adequate number of rapid tests in April, May, or June of 2020, hundreds of thousands of people wouldn't be on that list, would they?
I believe very firmly that they would not, and data from the UK supports that very much.
Dr. Mina, thank you for your work. Keep at it. Good to see you. Hope to see you soon.
Thanks so much.